Welcome to my presentation of sedation in the ICU. I don't have any disclosures, and these are some of the disclaimers. Also, I practice as an anesthesiologist 99.99% of the time and only get occasional calls for ICU sedation. So this presentation is from that perspective. And the 2018 PADIS guidelines will form the backbone of this presentation. I'm pretty sure you're familiar with this one. This is the Department of Health's daily COVID bulletin. As of the 4th of October, we've had about 112,000 active cases with 2.6% severe to critical. And critical patients are patients with impending or ongoing respiratory failure and in need of mechanical ventilation, or with evidence of end organ damage or with septic shock. In short, they are very sick patients. Although they are less than 2% of the total active cases, they comprise about 37% of the total number of ICU patients in the whole country. Majority, or possibly all of them, would need some form of sedation. And we, as anesthesiologists, having intimate knowledge in the pharmacology of anesthetic drugs, which we also use in the ICU, as well as being experts in mechanical ventilation, hemodynamic management, procedural experts in invasive line insertions, makes us extremely useful in an ICU setting, especially in ICU sedation. So hopefully, at the end of this presentation, we should be able to understand the common reasons why ICU patients require sedation, compare and contrast the common sedatives used in the intensive care setting, and hopefully formulate appropriate sedation management plan for particular cases. But before we proceed to the main presentation, I'd like to start with 3 case scenarios that we will try to formulate a sedation management plan at the end. So you just finished a 10-hour surgery on an unfortunate 33-year-old male who sustained a gunshot wound to his abdomen. So the surgical team did a surgical exploratory laparotomy, resection, and anastomosis. Patient bled a lot. They had to do splenectomy. But you managed to stabilize this patient. You replaced everything that needed to be replaced: blood products, electrolytes. He's not on any pressors. But it's late at night. You're tired, and you decided to keep him intubated and just send him to the ICU overnight with the intention to extubate him the following morning. The next case is a 64-year-old male who came into the emergency department with severe chest pain. While waiting, he crashed, and ACLS, CPR, chest compression, intubation, IV epinephrine, and return of spontaneous circulation. And then he was rushed to the cardiac cath lab for an emergency angioplasty. The cardio team managed to put in 3 stents, but intraoperative course was stormy, and the patient required balloon pump insertion plus dobutamine and IV norepinephrine infusion. And finally, this is a story that we are all familiar with. A 48-year-old hypertensive and diabetic female who contracted severe COVID-19, requiring initially high-flow nasal oxygenation. Failing that, she had to be intubated and now in a prone position, fighting the ventilator and with high-dose norepinephrine infusion. So we will go back to these cases towards the end of this presentation to see how we can best manage their sedation. I'm framing this presentation as problem-based ICU sedation because I believe it's important to identify specific problems our patients have in order for us to provide them with specific solutions or treatment. And distress is a big problem in critically ill patients because they experience this often, and it generally presents as agitation, possibly because they're intubated or having difficulty communicating with their relatives or caregivers. Distress needs to be treated for patient comfort, and because it increases sympathetic tone, which may have untoward physiological side effects. It may be caused by different factors. However, the administration of sedative analgesic medications should not be based on anticipated distress rather on that which is observed, meaning we should seek and quantify what's causing our patient's distress before initiating medications. Otherwise, there will be an increased risk of oversedation, which has been shown to worsen clinical outcomes. It may push our patients to the right side of this photo, causing ventilator-associated pneumonia, long-term decrease in cognitive function, hemodynamic instability, increased length of stay and cost, and post-traumatic stress disorder. On the flip side, inadequate sedation will expose our patients to pain, risk of self-extubation, misery, them being aware and awake, which can be distressing. So we want to be in the middle, not overly sedated and not under sedated. And that's where frequent assessment of our patients come into play. Common causes include anxiety, pain, delirium, dyspnea, and neuromuscular paralysis. These may occur separately or in combination, but usually in combination. So we'll try and discuss each of these causes, their risk factors for occurrence, how to assess each of them, and look at the different modalities of management or treatment. So we'll start off with pain. You get a call from the ICU asking for your help in sedating their patient. The first thing we must do is to get as much information about the patient, review the patient's chart, know the current status and medications the patient is on, like doing a preoperative evaluation. So we'll call it a pre-sedation evaluation. And then try and look for specific reasons why that patient needs sedation. And usually, pain is the first thing we need to assess and manage. And this is the concept of analgosedation. The concept here is that patients should be treated first before a sedative is considered. And in order to treat pain, we must have an established pain assessment protocol in our ICUs for us to identify and quantify the level of pain our patients have. So we have an analgesia first sedation, meaning we determine the level of pain our patients have through the use of pain assessment tools, which we will discuss later, titrate our pain medication according to the level of pain our patients have, and then provide sedation, usually a different drug, if our patients need it. The next one is analgesia-based sedation, which is quite similar to the first one, use of pain assessment tools, then treat with pain medications, but use the same analgesic, usually an opioid, as a sedative to reach the sedative goal. So how do we define pain? The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It is a strong driver of distress and agitation, so we might be wondering how common pain is and if it really does occur. The DahLIA study showed that 33% of ventilated patients experience pain at rest and 56% experience pain during a procedure. Mind you, these procedures can be as simple as suctioning, repositioning, physical therapy, to the more invasive procedures such as arterial line insertions, central line insertions, chest tube insertions. Also, immobility, trauma, surgery, the presence of endotracheal tubes, and other monitoring devices can all produce pain. As this paper showed, pain control should be a first priority in the care of the critically ill patients. And when we do this, there is a reduction in the duration of ventilator support and consequently the duration of ICU stay. There are benefits if one's ICU follows certain pain assessment protocols in their ICUs. So you improve patient pain scores, you decrease length of ventilation and ICU stay, you improve mortality, you consume less sedatives and opioids and increase non-opioid medications and eventually decrease opioid-related adverse drug events. And how do we assess pain? In the operating rooms, we are very familiar with using vital signs like blood pressure, heart rate, respiratory rate, oxygen saturation, and end-tidal CO2 as indicators of whether our patients are in pain, especially if we employ spontaneous ventilation techniques such as pressure support ventilation or CPAP. So we see increases of the respiratory rate and a subsequent decrease in the end tidal CO2 of patients we think are having pain, and we react accordingly. So we give additional opioids like fentanyl, and then after a few minutes, we start to see a decrease in our patient's respiratory rate and a rise in their end tidal CO2. In paralyzed patients, we use changes in the blood pressure, heart rate, and oxygen saturation and end tidal CO2 to gauge depth of anesthesia. However, these are actually not valid indicators for pain in critically ill adults and should only be used as cues to initiate further assessment using appropriate and validated methods. So, what assessment tools can we use in the intensive care setting? There are two methods. If your patients are able to communicate, then a self-reporting tool would be a good way to assess pain. You can either use the Wong-Baker Faces Pain Rating Scale or the Numerical Rating Scale. How do we do this? We first ask the patient if he or she is having pain. If yes, then we ask the patient to quantify his or her pain, and one way to do this is to use these rating scales, show this in front of the patient, and try to point at each of the faces or numbers, and the patient should be able to tell which face or number his level of pain is at that particular moment. If, however, your patient is unable to communicate, then behavioral pain scale or CPOT can be used. The behavioral pain scale uses 3 items to help us quantify our patient's pain. If the patient is grimacing with upper limbs permanently retracted and unable to control ventilation, then we can definitely tell that our patient is at the far end of the spectrum of the pain scale. If he or she looks relaxed, not moving, and not having any issues with the ventilator, then our patient may not be in pain or just having mild pain. The critical pain assessment tool or observation tool uses 4 indicators to assess pain. So facial expression, body movements. If your patient is intubated, its compliance with a ventilator, like if your patient is fighting with the ventilator or just tolerating the ventilator. If your patient is extubated, their vocalization, meaning how they talk, if they are talking in normal tone, or they're crying out or sobbing. Also, muscle tension, whether they're relaxed or very tense. In terms of which one is better to use, nonverbal or behavioral pain scales like the PPS or CPOT are better compared to the use of vital signs, but overall, self-reporting tools are preferable if your patients are able to communicate. And when do we treat pain in the ICU? According to the PADIS guidelines, pain medication should be routinely administered in the presence of significant pain. So an NRS of more than 4, a BPS of more than 5, or a CPOT score of more than 3. So once we know the level of pain our patients have, we then set our treatment target, usually a nonverbal pain scale of 0 to 2 or a CPOT of 0 to 1. And how do we treat pain in the ICU? Parenteral opioids are first-line pharmacologic agents for treating non-neuropathic pain in critically ill patients. Non-opioid analgesics should also be used as adjuvants to reduce opioid use, and non-pharmacologic interventions should be employed as multimodal treatment of pain in critically ill patients. Fentanyl is a good option, and we are very familiar with this drug. You can give this as intermittent boluses or IV infusion. However, we have to be careful in giving this as boluses. If we give it too quickly or too fast, it can cause chest wall rigidity, and that may cause problems ventilating our patients. It also accumulates in patients with hepatic and renal dysfunction. Morphine is another drug that we are familiar with. We can again give this either via boluses or infusion. However, it can cause hypotension and bradycardia in some patients, and it can accumulate in patients with kidney disorders. Its metabolites, like morphine 6 glucuronide, can accumulate and cause further sedation. So even if you've stopped your morphine infusion, sedation can persist. Morphine 3 glucuronide can cause neurotoxicity. Remifentanil is a good alternative, especially in patients who have hepatic or kidney dysfunction, because remifentanil's metabolism is via blood and tissue esterases. Again, it can cause chest wall rigidity if you give it too fast in boluses. And the most common side effect of remifentanil is bradycardia and hypotension. So we have to be careful in giving this in hemodynamically unstable patients. If your ICU is running out of intravenous opioids, then we can use oral oxycodone, 5 to 20 milligrams every 4 to 6 hours, but only in patients whose gut are working. It can cause hypotension in some patients, and we have to be careful in giving this in patients with kidney dysfunction. So we have given our primary pain medication in the form of an opiate like fentanyl. However, we all know that giving too much of these opioids can cause problems like respiratory depression, nausea, and dependence. So one way to reduce the use of opioids is to use adjuvants. It is recommended to use paracetamol as an adjunct to an opioid to decrease pain intensity and opioid consumption for pain management in critically ill adults. This paper by Memis, which was published in 2010, showed a gram of intravenous paracetamol given every 6 hours reduced opioid consumption, time to extubation, and nausea, but was also associated with hypotension in some patients. Ketamine is also a good adjuvant. The SCCM recommends its use as a low-dose infusion of 0.5 milligram per kilogram IV push, followed by a 1 to 2 microgram per kilogram per minute of infusion, but only in post-surgical adult patients. This paper by Gilou et al. Looked at the effects of small-dose ketamine in post-abdominal surgery patients in the surgical ICU and their morphine consumption. One group used morphine PCA with ketamine, and the other group used morphine PCA with placebo. VAS scores for both arms at rest and mobilization were similar. However, the total morphine consumption in the ketamine group was significantly smaller, and the incidence of side effects were similar, including the incidence of hallucination. Other adjuvants that we can use and is also recommended in the PADIS guidelines include gabapentin and pregabalin. However, this can cause occasional peripheral edema, and we must be careful in giving this in patients with kidney disorder. Just to highlight ketamine, it has an analgesic, anesthetic, amnesic properties without loss of consciousness. It can also cause sympathetic stimulation, which can cause increases in blood pressure and heart rate. Hypersalivation is also common with ketamine infusions, so be careful with our patients with endotracheal tube because it can cause endotracheal blockage. It can also cause hallucinations, and this side effect can be minimized by concurrent use of benzodiazepine, typically midazolam. And speaking of hallucinations and ketamine, which we all know is a known side effect of ketamine. However, this paper by Purbett et al., where they looked at the incidence of delirium and opiate consumption with the addition of ketamine in mechanically ventilated patients. So they had 162 ventilated ICU patients, and they were assigned to randomly to remifentanil and low-dose ketamine, and remifentanil with placebo. Key highlights include low doses of ketamine reduces delirium incidence and duration of ICU stay in patients in the ICU. And low doses of ketamine infusion induces no opiate consumption decrease, and remifentanil infusion does not induce hyperalgesia in ICU patients. So how do we incorporate these adjuvants in our pain management plan? The SCCM SPADIS algorithm gives us a guide on how to proceed. So you have to ask yourself, is my patient at risk of opioid side effects? Of course they are. All of them are. So if yes, then we can consider pharmacologic strategy to decrease opioid dose or side effects by adding adjunctive non-opioid analgesics. So if your patient has nociceptive pain or postoperative, so we can start giving them IV paracetamol, 1 gram every 6 hours, but be careful in patients with hepatic dysfunction. Nefopam is a non-opioid analgesic that exerts its effect by inhibiting dopamine, noradrenaline, and serotonin recapture in both the spinal and supraspinal spaces. It's a very effective analgesic. In fact, a 20 milligram dose has an analgesic effect comparable to a 6 milligram of IV morphine. And some would consider giving this not just as an adjuvant, but as an alternative to opioids. Low dose ketamine, again, we can start giving this in patients in combination with the other drugs mentioned. However, we avoid this in patients having hallucinations. And the data in clinical practice guidelines are restricted to surgical ICU patients. Neuropathic agents like gabapentin, pregabalin, and carbamazepine can be given in cardiovascular surgical ICU patients. However, we avoid this if the patient's level of consciousness starts to decrease. In neuropathic pain patients, we can again give neuropathic agents like gabapentin, pregabalin, carbamazepine, especially if our patients have Guillain-Barré syndrome or ICU-associated weakness. Other adjuvants that were tested but not recommended by the SCC and PADIS guidelines include IV lidocaine and NSAIDs of more than one dose, primarily because of risk of gastric ulcer, bleeding, renal injury, or immunosuppression. Non-pharmacologic techniques such as cybertherapy and hypnosis did decrease VAS scores and opioid consumption of alert patients. However, the risk of bias and imprecision of the data were judged to be so high that the authors of the PADIS guidelines did not consider this as part of the PADIS guidelines. However, the others like massage therapy, music therapy, especially if the patient chose the music, cold therapy, and relaxation therapy are recommended techniques. So if the patient's problem is pain, we provide pain relief first, usually through the use of opioids plus adjuvants to decrease opioid side effects and add non-pharmacologic interventions as part of a multi-component therapy. Another problem that can cause distress to critically ill patients include delirium. It is an organic mental syndrome and it isn't a specific disease. It is defined as an acute and potentially reversible impairment of consciousness and cognitive function that fluctuates in severity. Delirium occurs in 80% of ICU patients, but is frequently unrecognized in older individuals and in patients with hypoactive delirium. It may be associated with underlying causes such as infection, iatrogenic such as medications, or environmental. Prior to treatment, patients should be evaluated for a precipitating factor. In the acute phase, delirious patients have impaired short-term memory, abnormal perception, and intermittent disorientation, which is usually worse at night. Delirium is a risk factor for prolonged hospitalization and ICU stay, increased cost and mortality in critically ill patients. Risk factors include the use of benzodiazepines and blood transfusion, which are modifiable risk factors, and non-modifiable risk factors such as elderly with dementia, prior coma or emergency postoperative trauma surgical patients, and those severely sick according to their Apache and ASA scores. Again, as we mentioned earlier, we do not give our patients anti-delirium medications in the hopes of preventing it from happening, because that can cause harm to our patients too. We need to determine whether or not our patients are experiencing delirium through the use of assessment tools. Confusion assessment method for the intensive care unit or CAM ICU is a very common assessment tool used in the ICU. It has four features that need to be assessed: acute changes or fluctuating course of mental status, inattention, altered level of consciousness, disorganized thinking. So we start with a determination of the patient's RAS or Richmond Agitation Sedation Scale. Patients who have a RAS score of -4 and below, meaning they're deeply sedated or unconscious, would be very difficult to assess for delirium. So we start with a Richmond Agitation Scale of -3 and above. So we assess for acute onset or fluctuating course of mental status within the first 24 hours. If the patient has fluctuating mental status, then we proceed with the next one. If none, then you can stop the assessment because your patient is not delirious. If yes, then again, we go to the next stage for assess for inattention. So we ask our patients to hold our hand and we recite the 10 letters SAVEAHAART. Every time the patient hears the letter A, the patient's supposed to squeeze your hand. If your patients make a mistake of less than 3, then your patient is not delirious. But if your patient makes 3 or more errors, then we can proceed with the next stage and assess for the actual RAS of the patient. If the RAS is other than 0, then we can stop the assessment. Your patient is delirious. If the patient's RAS is 0, then we can ask a series of questions answerable by a yes or no. So example would be, will a stone float on water? Or are there fish in the sea? So if your patient makes a mistake of more than or equal to 2, then your patient is delirious. If it's less than 2, then you're okay. Your patient is not delirious. Another delirium screening tool that's being used in the ICU is the intensive care delirium screening checklist. There are 8 factors that's being checked using this tool. A score of 4 and above would indicate the presence of delirium. So how do we compare these two? When comparing these two tools, there are some advantages and disadvantages from each method. In general, the CAM ICU has a fast application, usually 2 to 5 minutes, and does not depend exclusively on the verbal response of the patient, thus being relevant for patients on mechanical ventilation. In contrast, the ICDSC is a checklist that can be implemented over 24 hours with easy administration and high sensitivity, but lacks specificity. The items of the ICDSC can be evaluated in the course of daily routine by nurses. Thus, while the patients are involved actively on the CAM ICU, they are indirectly involved on the ICDSC. Delirium in the ICU is important because it is associated with increased duration of mechanical ventilation, length of stay, and hospital cost. Even if your patients survive, delirium is associated with serious long-term effects such as neurocognitive dysfunction and psychological problems. As mentioned earlier, delirium is a syndrome and not a single disease. As such, the ideal treatment is to treat the underlying cause of delirium. If your patient is hypoglycemic, for example, then we should give glucose to this patient. If a medication is causing delirium, say a benzodiazepine like midazolam, then it would be best to stop that medication. Unfortunately, in most cases, there is no clear cause of delirium. Critically ill patients often have multifactorial causes of delirium, which makes it more difficult to treat. For distress due to delirium, antipsychotic medications such as haloperidol, quetiapine, ziprasidone are available. But we'll concentrate on the haloperidol because it's the most commonly used drug to treat delirium. It is a centrally acting dopamine antagonist, also used in the treatment of major psychosis. As mentioned, it is the most common drug recommended and most commonly prescribed treatment for delirium. However, Haloperidol possesses a number of side effects, including extrapyramidal reactions and neuroleptic malignant syndrome. But the most problematic effect in the ICU is prolongation of the corrected QTC interval, which can precipitate fatal arrhythmias. For these reasons, antipsychotic drugs should not be given routinely in patients in the ICU. Although this recommendation discourages the routine use of the antipsychotic agents in the treatment of delirium, patients who experience significant distress secondary to symptoms of delirium, such as anxiety, fearfulness, hallucinations, or delusions, or who are agitated and may be physically harmful to themselves or others, may benefit from short term use of haloperidol or any antipsychotics until these distressing symptoms resolve. Dexmedetomidine is recommended for delirium in mechanically ventilated adults where agitation is preventing weaning or extubation. It is a highly selective alpha 2 receptor agonist. Its major sympatholytic and sedative actions are mediated primarily via reduced transmission in the locus coeruleus, the major noradrenergic center of the CNS. Because of this, it has been argued that sedation induced by dexmedetomidine is more akin to natural sleep compared with other commonly available sedative agents such as propofol. In addition, because of its selective pharmacodynamics, it causes anxiolysis and sedation, but largely without the respiratory depression seen with most other sedative agents. Importantly, it also produces spinal and supraspinal analgesia via reduced nociceptive transmission, and this accounts for its valuable opioid sparing effect. The DahLIA study, or the dexmedetomidine to lessen ICU agitation, was a multi-center, double-blind, placebo-controlled parallel group RCT in mechanically ventilated patients who became so agitated that sedation could not be safely weaned for extubation. Data was collected on 71 patients, 39 who received a dexmedetomidine infusion and 32 received a saline infusion for a sedation target of RASS 0. The primary outcome for the study was number of ventilator-free hours up until day 7. Key highlights of this study include a significant difference in ventilator-free hours at 7 days, median of 144.8 hours for the dexmedetomidine group versus 127.5 hours for the placebo group, with no difference in the number of tracheostomies. The median time to extubation was 22 hours for the dexmedetomidine group versus 44.3 hours for the placebo group, and median length of ICU stay is 2 days shorter for the dexmedetomidine group. Delirium resolved more rapidly in patients who received dexmedetomidine 23 hours versus 40 hours, with a median of 2 additional delirium-free days during their ICU stay. Adverse events were rare. This meta-analysis by Ang et al. Demonstrated that dexmedetomidine reduces the incidence of delirium and agitation in ICU when compared with placebo. It also shortens the duration of ICU and hospital stay, duration of mechanical ventilation, and time to tracheal extubation. Non-pharmacologic techniques include a multi-component approach. These multi-component interventions include reducing modifiable risk factors like improving cognition through reorientation, cognitive stimulation like use of clocks, improving sleep like minimizing light and noise, improving wakefulness like reducing sedation, reduce immobility by early rehabilitation or mobilization, and reducing hearing and or visual impairment through the use of devices such as hearing aids or eyeglasses. It is important to note that we should not be giving pharmacologic agents to prevent delirium, sort of preventive delirium. So we have to be sure using assessment tools whether our patients do indeed have delirium or not before we start treatment. Anxiety is defined as a sustained state of apprehension and autonomic arousal in response to real or perceived threats. Fear of suffering, fear of death, loss of control, and frustration due to the inability to communicate are typical causes of anxiety in critically ill patients. Anxiety may be difficult to assess in these patients, especially in intubated ones. And patients may have difficulty expressing themselves, so this may be causing more anxiety in these patients. So we may want to be looking for signs and symptoms such as headache, nausea, insomnia, anorexia, dyspnea, palpitations, dry mouth, chest pain, diaphoresis, hyperventilation, tachycardia, hypervigilance. Identifying and treating the proximate cause of anxiety is always ideal as it may ameliorate both problems. Dyspnea, for example, is a common underlying cause of anxiety in critically ill patients. Thus, if inadequate ventilator flow is causing dyspnea with resultant anxiety, then the ultimate treatment for the anxiety and the underlying dyspnea may be adjustment of ventilator settings. Managing anxiety can include non-pharmacologic techniques such as reassurance and pharmacologic agents such as benzodiazepines or dexmedetomidine. The next two factors are somewhat related and we'll try and discuss them together. A lot of patients in the ICU are being referred to us because of some sort of dyspnea or ventilator asynchrony. Most of the time, sedation is not the solution to this problem. So let's define what dyspnea is first. It is a sensation of air hunger or feeling of suffocation. Evidence of dyspnea may include tachypnea, shallow breathing, diaphoresis, tachycardia, use of accessory muscles of respiration, hypoxemia, and or hypercapnia. Dyspnea may exist despite acceptable blood gas parameters. Strategies to alleviate hypoxia or dyspnea, such as adjustment of ventilator settings, if possible, should be explored first prior to the use of medications. Patient ventilator asynchrony is a whole different topic altogether, but just to define what PVA is, it is a mismatch between the breathing efforts of a patient and breath delivery of a ventilator. It is a common problem in mechanically ventilated patients and has an incidence of up to 80%. PVA may cause ventilator-induced lung injury due to excessive tidal volume and diaphragm injury from eccentric contractions, both of which can affect clinical outcomes. In this study by Beitler et al., published in 2016 in the Intensive Care Medicine, shows how breath stacking dysynchrony occurs and why it can be harmful. Focus your eyes on the shaded areas on the upper left portion of the photo. This is a flow curve of a patient on a ventilator. Everything above the x-axis is flow in and everything below is flow out. So the shaded area is basically the volume that's going in and out of the lungs. So you can see in the first shaded area, the patient's full breath in, and then there's a partial exhalation before another breath comes in. Normally, the inhaled and exhaled breath in that flow diagram should be almost equal. And that means the air you're breathing in, you're breathing out. But as you can see in this diagram, you have the first breath that's partially exhaled before you have a second breath superimposed. And if you take the net tidal volume of that second breath, it's going to be the sum of the two minus the small amount of exhalation. And that would probably happen in the succeeding breaths and that they were actually getting a higher tidal volume than what we initially set. So if we are following the ARDS ventilation strategy of small tidal volume, say 6 to 8 mils per kilogram, they were actually getting roughly 10 to 12 mils per kilogram of tidal volume, and we might be causing significant harm to our patients if we're not able to identify breath stacking. So how do we manage ventilator dysynchrony? As mentioned earlier, we optimize ventilator settings first. Failing that, we then can choose to escalate. We can then consider sedating our patients using analgosedation concept. So we provide some form of analgesia first using opiates, then consider adding sedative drugs to reach a RASS of -4 to -5. A low threshold should exist to escalate beyond analgosedation to the use of conventional sedative agents such as propofol, dexmedetomidine, or benzodiazepines, and that means using paralytics as well, especially when any of the following conditions exist. If your patient is at risk for unplanned device removal, meaning extubation, despite the use of analgosedation and appropriate use of restraints, or if your patient has significant ventilator dysynchrony with evidence of impaired gas exchange despite the use of analgosedation. Just a quick look at this table presented earlier with special attention on the adverse events and patient considerations for each drug. Tailor our opioid choices to our patient's medical condition. Remember to add adjuvants like paracetamol to decrease opioid dose and side effects. You can then think about sedating and possibly paralyzing our patients if ventilator dysynchrony persists. Benzodiazepines can be given and are said to relieve anxiety, agitation, prevent alcohol withdrawal, treat seizures, status epilepticus, provide sedation and promote sleep, has amnesic effects, and can be given in patients receiving neuromuscular blocking agents since NMBAs don't possess any analgesic or sedative properties. As mentioned previously, benzodiazepines are associated with increased incidence of ICU delirium. So we'll go through three of the most common benzodiazepines. Midazolam, we are very familiar with this, is a GABA agonist. It can be given by boluses or infusion, but it can cause respiratory depressions and it can accumulate in patients with hepatic or renal impairment. Lorazepam is another benzodiazepine, but we seldom give this in the ICU. It can be given via infusion or boluses, but it can cause metabolic acidosis in some patients and is attributed to the lorazepam additive, which is propylene glycol. Diazepam can be used as well, but we seldom use this. We only use this in patients with alcohol withdrawal. Again, it can cause respiratory depression and can cause propylene glycol toxicity. So we've touched on the neuroleptics earlier, and we're not going to dwell into them again, except to reiterate that they are not commonly used as sedatives in the ICU because of their side effect profile, but are still effective for intermittent single dosing for delirium, especially haloperidol. Barbiturates like pentobarbital and thiopental are not commonly used in the ICU. They have specific uses like management of increased ICP, seizure burst suppression, or to induce coma. Side effects include excessive sedation, respiratory, and myocardial depression. Again, dexmedetomidine is a highly selective alpha-2 receptor agonist with effect on the locus coeruleus. It has opioid-sparing effect via supraspinal and spinal analgesia and has dose-dependent hypotension and bradycardia effect. Contraindications to the use of dexmedetomidine include hypersensitivity to the drug, those who have unpaced second or third degree heart block, those who have uncontrolled hypotension, and those who have acute cerebrovascular conditions, and those who are taking other alpha-2 agonists such as clonidine. Special precautions for patients who are at risk of exaggerated cardiovascular response such as hypovolemic patients, those who have spinal cord injury, those who have severe left ventricular systolic dysfunction, and those who have given neuraxial anesthesia, those who are pregnant, breastfeeding, and have seizures. Propofol is a commonly used drug in anesthesia and intensive care, where its favorable pharmacokinetics and rapidly reversible sedation make it an ideal drug for short-term sedation. It may be given as an infusion of 5 to 50 microgram per kilogram per minute and is particularly useful in patients requiring deeper sedation. Adverse effects include hypotension, bradycardia, myocardial depression. Also, propofol can cause hypertriglyceridemia due to its 10% fat emulsion. Triglyceride levels should be monitored every 24 to 48 hours and should be stopped if the levels exceed 800 milligrams per deciliter to prevent pancreatitis. One potentially fatal adverse effect of propofol is PRIS, or propofol-related infusion syndrome. It has an incidence of about 1.1% and is more common in children. The incidence increases in the setting of known risk factors, including increased propofol doses, use of vasopressors or corticosteroids, and critical illness. It can present as metabolic acidosis, rhabdomyolysis, hyperlipidemia, enlarged or fatty liver, and acute refractory bradycardia leading to asystole. Treatment options are limited. Hemodialysis or hemoperfusion with cardiac pacing and cardiorespiratory support has been the most successful treatment. If after you've optimized your mechanical ventilation, you've given fentanyl and started sedation initially to a RASS of -2, and the patient settled and the patient is no longer having ventilator dysynchrony, then you can stop there. But if the patient continues to struggle despite those maneuvers, you can now consider giving neuromuscular blockers. Increase your sedation to a RASS of -4 to -5 first before you paralyze your patient. NMBAs are not first-line agents for managing undesired movement, agitation, or ventilator asynchrony since they do not have sedative, amnesic, or analgesic properties. NMBAs for these indications are generally reserved for patients in whom conventional strategies of sedation and analgesia have failed. In such circumstances, NMBAs may be used for severe, refractory, or life-threatening hypoxemia, particularly those with severe ventilator dysynchrony. NMBAs may help to achieve lung protective ventilation through prevention of spontaneous respiratory efforts and by reducing oxygen consumption through decreasing work of breathing and abolishing resting muscle tone. NMBAs may also prevent injurious regional lung overinflation and dynamic hyperinflation. Overt shivering due to therapeutic hypothermia following cardiac arrest. Eliminating unwanted movement or reducing muscle tone in patients with refractory status asthmaticus, patients with raised intracranial pressure or who have unwanted muscle movement or ventilator dysynchrony contributing to raised ICP, patients with massive hemoptysis to prevent coughing and clot dislodgement, patients with conditions that increase muscle activity like tetanus, malignant neuroleptic syndrome, and patients with increased intra-abdominal pressure or patients who need temporary paralysis to facilitate short procedures like bronchoscopy, endoscopy, radiologic interventions. Also, treatment in acute respiratory failure requiring emergent intubation. How do we select neuromuscular blocking agents? So we look at the patient's medical conditions. If your patient has hepatic or renal impairment, then we can choose cis atracurium or atracurium because of their metabolism. In older adults, there is an age-associated decrease in cardiac output and hepatic function. In obese patients, agent selection is the same as non-obese. If your patient is septic and with septic shock, they have delayed and reduced response to standard dosing regimens of cis atracurium. And hypothermia may prolong the duration of action of non-depolarizing muscle relaxants. To be honest, most of these cases, I would still use cis atracurium or atracurium. Bolus or infusion, this will be up to the indication and the clinical scenario. Of course, if it's just for intubation, then it would be a bolus dose only. Post-cardiac arrest patients on therapeutic hypothermia would greatly benefit from an infusion of NMBs if the patient is shivering. Some ARDS patients would benefit from a single bolus of NMBs or an infusion, especially if they are in prone position with heavy sedation. But not all patients on prone position need neuromuscular blockers. If you need to start an infusion, try to limit it to less than 48 hours and make sure you have enough nurses to look after your patients. Some ICUs are not capable to have an ideal nurse to intubated patient ratio of 1:1, so probably you might want to have extra monitoring equipment in place to monitor ETT disconnection, for example. The adverse effects of neuromuscular blocking agents in critically ill patients are similar to those experienced by patients undergoing anesthesia. The most commonly encountered side effects in critically ill patients are allergic reactions, usually the IgE mediated type, and succinylcholine and rocuronium being the most frequent. Just be aware that cross-reactivity between NMBs is possible and has happened in 60% of cases of anaphylaxis. Cardiovascular side effects like hypotension is usually from vasodilatation from histamine release. Drugs with lowest CVS effect risk include cisatracurium, rocuronium, and vecuronium in no particular order. Succinylcholine can cause hypertension and tachyarrhythmias. Prolonged paralysis, typically tetraplegia following drug discontinuation, is unusual and results mostly from accumulation of drug or active metabolites or from ICU-acquired weakness. Other NMBA adverse effects pertinent to critically ill patients include awareness during paralysis, coronal abrasions, infection and scarring, venous thromboembolism, and decubitus ulcers. The risk of such complications can be reduced by supportive measures. So we've reached the end of my presentation, and now we go back to the three scenarios I mentioned earlier, and we'll try to formulate a sedation plan for each of them. First one is the 33-year-old who sustained a gunshot wound to the abdomen, post-exploratory laparotomy, resection anastomosis, splenectomy. You stabilize this patient, transfuse blood, everything, not on any inotropes or pressors, but you you had 10 hours surgery and you're tired, so you sent this patient to the ICU. And how do we manage the pain of this patient or the sedation of this patient? So we assess pain of this patient first by using pain assessment tools like behavioral pain scales or the CPOT. Knowing the pain level of our patient, we then try and start IV opioids like fentanyl and add adjuncts like IV paracetamol 1 gram every 6 hours. And we can use that as analgesia-based sedation. And if your patient is okay with that, then we can leave the patient with that sedation. But if you think that the patient needs more sedation, then we can probably add propofol or dexmedetomidine. I would choose dexmedetomidine in this case because of the opioid sparing effect of dexmedetomidine. So using that, I would be able to reduce my fentanyl and reduce the side effect of fentanyl. And then I'll try to stop the sedation early in the morning and try to extubate this patient as soon as possible. The next case is the 64-year-old male who had acute myocardial infarction, who had severe chest pain initially, and then he crashed and they had to do chest compression, ACLS intubated, 3 stents put in, and then they had to put a balloon pump on his groin. Hemodynamically unstable on both dobutamine and norepinephrine infusion. So how do we manage the sedation of this patient? So because this patient presented with chest pain initially, and they had to do chest compression in this patient with endotracheal tube and a balloon pump on his groin definitely this patient has pain, but we still need to assess his pain by using pain assessment tools such as PPS, especially if this patient is non-communicative. If we've determined that indeed this patient is in pain, then we can start IV fentanyl with IV paracetamol 1 gram Q6. Because this patient collapsed and they had to do return, you had to resuscitate this patient. The team might be using therapeutic temperature management or therapeutic hyperthermia. Then patient may need sedation. Again, this patient is hemodynamically unstable, so propofol, dexmedetomidine may not be good choices. So possibly midazolam would be a good alternative, bearing in mind that midazolam can cause delirium. If the patient is shivering during the therapeutic hypothermia protocol, then you can consider giving paralysis to this patient. But we need to increase the sedation of this patient to a RASS of -4 to -5 before you paralyze this patient. And lastly, the critical COVID patient with fighting the ventilator had to be prone, still having respiratory deterioration, but on high dose norepinephrine infusion as well. So she's hemodynamically unstable. Again, definitely this patient is having pain, but if the patient is still awake, we can ask the patient directly what the level of pain she has by using the Wong-Baker Faces scale or the numerical pain scale. And then we can start fentanyl infusion plus IV paracetamol 1 gram Q6. And then we try and optimize the ventilator settings. If we're uncomfortable doing that ourselves, then we can ask our internist colleagues to help us do that. They probably have done that already. If after that optimization, your patient is still fighting the ventilator, then we can probably increase the sedation. Increase using what? Again, this patient is on high dose norepinephrine infusion. So propofol, dexmedetomidine, both can cause hypotension, myocardial depression, and bradycardia. So maybe not a good choice. So midazolam or ketamine can be a good alternative. If again your patient is still struggling with the ventilator and still fighting the ventilator with continuously deteriorating respiratory function, then increase the sedation to -5 of RASS and then paralyze this patient. So to summarize what we have discussed, there are a number of causes why our critically ill patients need sedation. If they are anxious, which is difficult to quantify, a bit of reassurance might help. Failing that, we can give dexmedetomidine or benzodiazepines. If they are in pain, we can give opioids plus adjuvants like paracetamol to decrease opioid use and side effects. If the patient is struggling with the ventilator, then we should try and optimize ventilator settings first. Failing that, we can start analgosedation with IV fentanyl, IV paracetamol, or IV dexmedetomidine, and aim a RASS of -2 initially. If that fails too, then we can deepen the sedation to -4 to -5 and consider giving paralytics. But try and limit your paralysis to less than 48 hours. If your patient has delirium, then dexmedetomidine is a good first choice. But if the patient is in severe agitation, which is causing harm to himself or others, then we can give stat IV doses of haloperidol. Most of these problems have their own assessment tools, so we must familiarize ourselves and try to use them. If the patient needs to be sedated, then we should aim for a light sedation or a RASS of -2, possibly -1 and above. And if we think about it, apart from the use of anti-delirium drugs, we pretty much do the same thing when we give anesthesia to our patients. So pre-induction, we assure or give midazolam to our patients if they are anxious with their surgery. Intraoperatively, we titrate our opioids, our propofol, muscle relaxants, and give intravenous paracetamol. And we do this because we want to decrease the side effects of each of the drugs we give while still providing adequate anesthesia to our patients. And we call this balanced anesthesia. Would it be appropriate then to label what we do in ICU as balanced ICU sedation and have that in mind as we approach our ICU sedation management? And with that, I would like to sincerely thank you for sticking till the end, and I hope you learned a lot. And please stay safe.